Welcome to the Joe Cohen Show. Join me as I share my experience with biohacking and invite top health experts to explore the latest technology, supplements, research, and resources for optimizing your body and brain. Hey everyone, I'm here with Dr. Anil Bajnath. He's an MD, board-certified physician, and he's the author of The Longevity Equation, the step-by-step blueprint to hack your genes, optimize your health, and master the art of existence. He's currently a professor at the George Washington University School of Medicine, where he teaches a course on omics. So that includes genomics, proteomics, and metabolomics. He is the CEO and founder of the Institute for Human Optimization Precision Medicine Research Group, located in Maryland. And, I met Dr. Anil based on he's a significant user of SelfDecode. He uses the platform quite a lot, and I found him quite interesting. And, he was mentioning that most of his patients are actually MDs. And, just speaking to him a little bit, it seems like he has this good balance of skepticism and open-mindedness, which I like. Often too many MDs are either too close-minded or sometimes they believe in too much bullshit. And so I kind of like that, Dr. Anil is more of a skeptic, but he's also quite open-minded. And in general, he, what we could say he's into functional medicine. So yeah, I mean, you've been in this, how long have you been in this industry for? You mentioned from a young age, you're already reading about health and this stuff.
Yeah, Joe. Well, again, thank you for having me. It's a pleasure to have the opportunity to speak to you and, everything that you guys are doing at SelfDecode. So my story basically begins as a teenager. We were getting, I was mentioning to you how I've taken a trip to Israel after I graduated medical school because, all my buddies that I wrestled with in high school went in and volunteered for the IDF after graduating high school. So after I graduated medical school, I went and paid them a visit and spent some time in Jerusalem and Tel Aviv. And, it was a lot of fun. But I got into, natural health or integrative modalities when I was in high school. I worked at a Whole Foods market at the age of 16, selling supplements to stay out of trouble. So basically, I got my first exposure to the nutraceutical world at the age of 16 and learned all about, all the different vitamins, minerals, herbal preparations, homeopathics, and so forth within the industry and space. And at the time, this was before pre-Amazon, when the hippies owned it and John Mackey, and it was a different culture. We would have all these different nutraceutical reps come into Whole Foods and educate us almost like a pharmaceutical rep would in regards to the research and the science and the intention behind these products. And we would go out to dinners and I would meet all sorts of wonderful, different doctors that helped, educate the space and the products and everything else. So I started my kind of, informal medical education in the nutraceutical industry. And then, when I was 18, the company Gaia Herbs, I don't know if you're familiar with Gaia, but they're a
Yeah,
pretty big,
absolutely.
yeah, herbal company, sent me out to a conference in foothills of Asheville, North Carolina, and essentially got the pleasure of meeting the former and late dean of Bastyr University. And if you may know, Bastyr University is a, well-known naturopathic institution here, stateside. And
Absolutely.
before he passed away, he said, become a medical doctor and always infuse the natural modalities. So that's kind of what I did. And additionally, my high school wrestling coach and one of my coaches knew that I was working with the nutraceutical world and introduced me in a technique that I think is pretty remarkable in regards to really connecting and identifying with my patients. And so when I was 19, I got into a technique using dark field phase contrast microscopy, bought a scope and started analyzing everybody's blood. Take a drop of blood, put it on the microscope, and I'm able to take a deep dive into what's going on a qualitative reflection within the blood. It led me down multiple different roads, including studying European biological medicine with the Paracelsus Clinic of Biological Medicine. Switzerland.
Question.
Mhm.
Yeah, could you quick question. Is that approach to analyzing the blood legitimate, like, in
Yeah,
hindsight now?
great question. So this is where I had the training from the alternative side. And then I also went on to major in molecular microbiology and medical laboratory science. And I worked in heme path labs. I spent some time at MD Anderson Cancer Center. And in my opinion, that dark field phase contrast microscopy is very operator dependent. So you
Mm,
will see, really ethical and efficacious morphologies under the blood. It's the same thing as doing a peripheral blood smear, right? In any lab. The difference is how you prepare the slide. There's, the capillary dispersion when you take the slide to the fingertip versus the feathered edge by taking a drop of blood from a tube and then scraping it against the slide to get that peripheral feathered edge. So just
mm,
like a conventional blood slide, you don't go at the base of that edge or, at the beginning because the blood looks like shit, right? But if you go towards a peripheral edge where it's dispersed appropriately, you're going to get a better reflection of what's going on within the blood. So,
mm.
in my opinion, it's operator dependent. There's a lot of charlatans out there that are just trying to basically sell you a bunch of supplements and nonsense. However, to the astute clinician and physician that's using it, not to sell you supplements, but to take a deeper dive into the terrain of the blood, there is a lot of efficacy there. And
Okay, interesting.
yeah, and in Germany, Switzerland, and Europe is what they kind of, do at these clinics to monitor your progress. Why? Because again, if we're to take a CBC, complete blood chemistry profile, and we're to break down all those different numerical values, RBC, hemoglobin, hematocrit, distribution with, MCH, MCHC, and so forth. Well, that's what we're looking at in the live blood. But we would even see a lot more different morphological characteristics. You could see membrane lipid peroxidation and free radical damage, which with spiky acanthocytes and echonocytes, which is associated with, maybe poor, trans fatty acid intake or smoking or something that's going to go in there and accelerate lipid peroxidation. You could correlate that numerically with like a malondialdehyde on the blood chemistry profile, but
Hmm.
all sorts of stuff in the blood. It's super fascinating. I do it as a research tool to also look at the lipid dynamics with chylomicrons in the blood, which are little fat particles, the smallest little forms of fat particles. And, look at also additional cardiovascular stress, like morphology, fibrin formation, anesicytosis, which influences the hematopoiesis or the production of the cells and the variation of red blood cell size and shape, which isn't always captured in the complete blood chemistry profile appropriately. So I'll chat your ear off about that all day. But I got into that technique at the age of 19, analyzed everybody's blood, went on to study the European methodologies behind this and its clinical applications, and then formalized the education with my undergraduate degree in molecular microbiology and medical laboratory science, where I worked in conventional hematology. And then before starting medical school.
Okay, that's very interesting. I mean, like, up until there's certain things that I hear about, and then I don't know if it's legit or not, but now I think the way you described it makes sense that there's legitimacy to it if you have the right person who knows how to do it. But it also seems like you can a lot of the things that you would figure out from that, you could also just take a blood test and see, right?
Yeah, to an extent, I think the blood tests, to the patient, they're just going to see a bunch of letters and numbers that make no sense. But I think that qualitative impact that the person, you know, receives by viewing their undenatured blood is pretty profound.
Mm,
And again, it's just there's a lot of things that you will see that go beyond what's captured in regular blood work. For example, I see endotoxemia all day long, right? So if you have
okay.
somebody that has postprandial metabolic endotoxemia where they're shedding their microbiome into peripheral circulation, we'll see those little microbial forms within the blood, you know? It's
Interesting.
there.
So you can
And
see endotoxemia in the blood.
Yep, yep. Oh, well,
Wow.
that's what
And most
endotoxemia
people
is.
you think have it or don't have it?
Well, it depends. I would say it depends on the meal. It depends on leaky gut status and zonulin. It depends on multiple different factors. But if you're eating a diet that is, I think, low inflammatory and your gut is generally well, you're not going to see that profound endotoxemia. You will
Mm,
see some maybe chylomicrons that, postprandial after you eat, you'll see some chylomicrons or little fat particles in the blood, but you shouldn't see the bacterial shedding within the blood, but you
mm,
see it. So it depends on the
interesting.
individual, right? And this is, gets into the work of what's now being called the blood microbiome, which is a very
Mhm,
fascinating area. We know we have a skin microbiome, a gut microbiome, and a sinus microbiome, an oral microbiome. We also have a blood microbiome. The blood is not sterile. And a lot of that is heavily influenced by what's, kind of seeping in from the microflora in the of the gut.
interesting. You wanna hear about the one health hack that is sure to change your life? Okay, here it is. Subscribing to this podcast. 67% of listeners aren't subscribed to the show, so please don't forget to show your support by hitting the subscribe button now. You'll not only be supporting the show, but also investing in yourself and your health journey, all while helping to keep us ad free. Take us through your approach in when you get a patient come to you. How do you what is your approach? What is your process? Your intake, what are you looking at? What kind of tests? Like just I guess start from the general and then we could drill down more into the specific.
Yeah, that's a good question. I think a lot of it depends on the clinical presentation. In my private practice with the Institute for Human Optimization, I actually try to, curate this multi-omic approach to individualized care, which is truly translational precision medicine. I genotype everybody, and depending on what kind of clinical presentation they might have, influences which DNA test that I go with. For the most part, I use SelfDecode as a baseline, just because I think it gives a great overarching kind of clinical interpretation of very important aspects polygenetically to health. So I really appreciate that platform. What are you going to do once you find out that you have these inborn errors of metabolism? Because again, there's a
Mhm,
difference between genomics and genetics. And genomics, for your audience that may not know, is basically everything. All the data, all the genes, right? The 20,000 plus different genes that are within your system, and looking at how maybe there might be these single nucleotide polymorphisms or SNPs, which is basically you could have a codon, which is a set of three different nucleotides. And let's say that's ATT. A SNP would be a variation where it might be ACT instead of ATT. And that influences the protein or the amino acid that's going to be coded for within that protein. And sometimes, if there are enough of that, penetrance of variation, it will influence the protein that's being coded and its enzyme function and the folding. And that influences physiology. So genomics is taking bigger approach to looking at all the different variables within an individual, whereas genetics is very classical Mendelian in nature, where we're looking for those inborn errors of metabolism that could be influencing really negative specific pathways. That's your cystic fibrosis, your PKU, and your all those genetic diseases that you learn about, in medical school or in school, is what that kind of refers to, but where we're using this information on a global scale. So I like to genotype individuals to know what I'm working with. Pharmacogenomics is also a very important, kind of component for me clinically. However, my goal is not to accelerate, the pharmaceutical burden within somebody. I'm not,
mhm.
I do prescribe medicines. I do prescribe statins. I do prescribe, drugs when needed. But my goal is to work with you as holistically as possible, not to increase that burden. So I will use, like I said, genomic testing depending on who and what and where. I also use transcriptomic testing in the sense of, this is looking at RNA and how your DNA is behaving. So essentially, if you were to put this into an analogy, RNA is essentially, the transcriptome is basically measuring the harmony coming up. your own DNA, right? So if the DNA was your own, were the individual instruments for your own personal symphony orchestra, measuring that harmony is the actual RNA expression. Certain genes have the ability to be kind of upregulated and turned on, and certain genes have the ability to be downregulated and kind of less pronounced in function.
So,
So
in the bigger picture of things, you're talking about epigenetics,
So
right?
epigenetics is a little bit different than
Mhm,
transcriptomics. So transcriptomics is referring more to how that gene is behaving, right? So it's not asking what type of gene do we have, but more specifically, how is, I don't know, my FKBP5 gene, right? FKBP5 is a very important gene that influences PTSD. And
mhm,
needless to say, I have a lot of patients that have gone through a lot of issues and have a lot of health trauma or just trauma from childhood, whatever it might be. And then sure enough, you were to correlate that with the ACEs score, that adverse childhood event survey, there's oftentimes a significant association with a score of 4 or higher and that that kind of increased expression of the FKBP5 gene. Right?
mhm,
So, whereas epigenetics is referring more specifically to the methylation, acetylation, uh, various CPG islands or base pairs, and how that's kind of tightening around the histone protein more specifically. So we use transcriptomics usually in the context of chronic complex illness and trying to decipher if there's an environmentally acquired influence on their health expression. For example, what I work with another clinical setting that I'm in is with my mentor from the university, George Washington University, Dr. Andrew Heyman. And this is where we kind of, unpack a lot of, mold issues, SIRS issues, chronic inflammatory response. And that's where we typically use the transcriptomic testing at play. But, that's just one sliver. And then also proteomics, so proteomics is all your advanced biomarkers. And typically, like I, say it all the time, we're going to see a molecular signature and a pattern associated with four common kind of signatures. And that's going to be inflammation, oxidation, ischemia, and immune dysregulation. Those are the four common, patterns that we see that drives pathophysiology. We all know what inflammation is. Oxidation is essentially a loss of electron, and that's, the analogy behind that's cutting an apple open and watching it turn brown over time due to that oxidative process. Ischemia refers to low oxygen, and ischemia gives rise to all sorts of different, pathologies or molecular activation between fibrinogen and hypercoagulation, platelet activity, not to mention perfusion patterns to the cerebrovascular system. So ischemia plays a very important role as a whole, and dysoxygenosis, which is, the balance of oxygen in the system on a both on a larger scale and on a micro level. And then immune dysregulation is pretty self-explanatory. A lot of individuals unfortunately have perturbations in their immune system that push them into a subset of imbalance within their immunity, Th1, Th2, Th17 most notably, and that could influence their pathophenotype. So we use proteomics to further, map out, what's going on, are we seeing the signature of inflammation, oxidation, ischemia, and immune dysregulation? And then I also like to use, the microbiome to see if there is this gut microbial association with, again, their pathophenotype, because we know that, a lot of disease begins in the gut. Right. And as we kind of, mentioned here in the beginning of the discussion with leaky gut syndrome and how, that could influence metabolic endotoxemia and also immunological programming, because again, 70 to 80% of your immune system is found within your gut in the form
mhm.
of gut associated lymphoid tissue. So it's very important, key regulator at influencing things. So I like the microbiome. I also look at the epigenetics and I use epigenetic testing clinically. I also look at the exposome. So if we are concerned that they're in a environment that's not, suitable for them.
What is the
What is it?
exposome exactly?
So exposome refers to how the environment or these different environmental factors are influencing your clinical presentation. So for example, if you live in a moldy environment and and you have a high ERMI score or Hertz Me Too score, we're going to look for that. We're going to look at endotoxins
Which
in
is the
the
mold score in your house? different mold
Correct,
scores.
correct. And then I also use it in the context of looking at other exposomic information, heavy metal testing, and different, kind of environmental toxic exposure through
Okay.
urinalysis. So I try to connect the molecular dots with, genome to pathophenome and looking at genomics, transcriptomics, proteomics, metabolomics. I also use metabolomics, epigenetics, microbiomics, and the exposome. So to
That's incredible. I think that's really cutting edge stuff that you're like, I hearing you say all this stuff, I'm like, why is this guy not my doctor?
Well, and that's how it's weird. I've become the doctor's doctor, directly and indirectly, just like, my former residency program director is, sending me his patients and shares so much information. And it's just, I think it's mostly physicians see the value of what I'm doing and they understand the science and they realize that this is the future of medicine. What I just described is precision medicine in a nutshell. I
Yeah.
mentioned to you I wanted to have our discussion after I attended a conference at University of Pennsylvania last week and with a precision medicine leadership summit. And there was researchers from all over the world, from the top institutions that are going there and presenting their research on diabetes, cancer, hormones, pharmacogenomics, and cardiovascular disease and so forth. And, I went up to, some of the key organizers and I told them, "Hey, this is what I'm doing. I'm in the trenches, essentially in primary care, with individuals and this is how I'm using precision medicine." And they're like, "This is incredible because right now it's only in the major academic institutions at these centers of excellence where they're doing it. But the biggest
Right.
problem, they're using it in the context of drug discovery and development. Whereas we're not going to find that magic bullet. I'm sorry. We need to take a step back and look at things more holistically. We need to see if we're seeing these patterns of inflammation, oxidation, ischemia, immune dysregulation, and correct that. We need to use a functional medicine lens to go on, go in there and do a root cause analysis to see what's really creating these perturbations or imbalances within the system and identify and address that. And then hopefully we could shift the narrative towards longevity instead of disease management. Because, when it comes down to it, all the 12 different hallmarks of aging influences your pathophenotype and
Right.
disease development. So, my whole narrative is multi-omics in medicine, N of one care, quantified self, and longevity. That's if you were to sum up what my goals are clinically, that's kind of my
I love
approach.
that. That's my philosophy as well. I wanted to discuss so just some of the negatives or counterpoints of why somebody might not do these tests or whatever. And, I could give you my opinion and we could kind of
Please.
discuss through that. So, first of all, I think everything you're doing has some value, which is good, right? And I think that the problem with a lot of these fields, like transcriptomics, I would say epigenetics, microbiome, first of all useful. I'm, either I've gotten the test done or I'm going to get the test done, but I would consider myself, quite advanced, right? Like the epigenetic test, I'm going to be getting done now. But the negatives are, for example, microbiome. There's not enough information on what these things mean or what to do about them, right? Like, for example, I just saw a study, a Mendelian randomization study, which is teasing out some causal effects that actually found that people with higher microbiome diversity lived less long, right?
Mhm.
So it's like, you normally would assume that more microbiome diversity is better, but then they came out with that it's less. I don't know what the real answer is, but there's I'm just saying, like, there's too much we don't know about it. And when I got my test, I didn't really know. Maybe if I would like to look at the results again just to because I did a lot of research on it recently, but it really is heavily dependent on the person who's doing the analysis, I think, because you really have to. I don't think there's any really good software that just takes care of that. Or same with transcriptomics, and then you could get transcriptomics in the blood, but that's not necessarily going to be relevant for the liver or some other organ or the brain.
Yeah.
Would you agree with that?
It just depends. So, transcriptomics from the blood, there's going to be tissue specific transcriptomes, right? So
Right.
you're absolutely right. The cervix versus the hepatocyte's going to have a totally different kind of gene expression, right? I would make the argument that blood might be one of the more relevant sources of information just because the blood nourishes and bathes all tissues and it is receiving signals and inputs from those tissues. And then, these organs are spitting out information into the blood that influences the blood
Mm.
transcriptome. I also agree that we are in our infancy when it comes down to the microbiome. We we are light years away from really making actionable steps and understanding the full dynamics of the microbiome because it's so transient. And we know that your bowels change throughout the day, right? So but from a clinical perspective, I will say that with the right test, it will shed some additional light in regards to, hey, is there a gut dysbiosis? Is there a SIBO or a small intestinal bacterial overgrowth? Is there increased fecal calprotectin, which is conventionally accepted and associated a biomarker for IBD, irritable bowel disease, such as ulcerative colitis or Crohn's disease? Is there, an increase in zonulin, which is clearly established to be associated with leaky gut syndrome?
And you're
You
gonna
know,
get that with a microbiome test or like a stool test?
this
Which
is a stool test, but,
Okay.
the microbiome, just getting the snapshot of all genome-wide sequencing of the gut microbiome has very little clinical utility and benefit at this time. But we
Right.
are finding, different studies that are coming out, whether it's on Akkermansia or Fusobacterium, Bifidobacterium, so forth, and its role in disease progression, right? So, knowing if there is a signature on some of these heavy hitters could point us in the direction of saying, hey, low Akkermansia or Akkermansia is associated with metabolic syndrome and diabetes and think, poor glucose control. That's pretty well established
And
in the
then you
literature.
can supplement that. They have individual
Yeah,
species.
yeah, they
I've
have.
taken a megadose with that.
Yeah, yeah, and, in my opinion, though, I still think the gut microbiome should be viewed in the context of terrain, right? Instead of the microorganism. It's almost like the polygenic terrain or polymicrobial terrain of the blood.
So what would that be, like bifidobacterium or
Yeah, exactly. So, certain diets shift the terrain of the gut. The more we eat meat, unfortunately, we upregulate various species that are associated with producing, putrescine and cadaverine as metabolites versus eating plants. More plants have, a different effect on the gut microbial
but
balance.
do putrescine and cadaverine then turn into spermidine?
There are arguments that that could be some of the stream kind of
Which could be an
metabolites.
upside, right? Because spermidine is generally viewed as
Potentially,
good.
potentially.
Yeah.
And there's certain foods that beyond meats that do that. But, essentially though, our gut microbiome changes, based on our signals and inputs, So in my book, I mentioned, this concept of biological 401k. Right. I've trademarked this term biological 401k. Within us, we all have our biological health savings account for which we're making daily deposits and withdrawals in various forms of energetic epigenetic currency. Deposits is everything good: sleep, nutrition, exercise, meaning and purpose, relationships, so forth. Withdrawals is everything bad. Drinking excessively, smoking, poor sleep, toxic relationships, shitty environment, all that stuff, right? So at the end of the day, our count is measured based on our biological age, right? And this, goes beyond Horvath clock or whatever. There's, I've shared with your team the phenotypic age calculator, that's kind of been vetted by the NIA, National Institute of Aging. And I think that's another kind of surrogate reflection of your biological age. And
We're gonna integrate that into self-decode, as I mentioned. Yeah.
thank you. Thank you. So I think, ultimately we have this biological 401k. We're making daily deposits and withdrawals in different forms of epigenetic currency. And our ultimate ROI or return on investment is going to be, making meaningful investments. That's going to translate into health span over a lifespan. And as you know, health span is that time, that's unencumbered with disease or dysfunction or disability. Whereas lifespan's a total number of years that we're alive. We all know that the biggest spend on average is the last few months of life, right? Just trying to prolong, I hate to say it, sometimes the inevitable, right? So that end of life care is where the greatest burden of healthcare expenditure comes from. But what if we could just grow old gracefully and just die in our sleep naturally, peacefully, around the ones that we love and not in a hospital bed, you know? That's, real talk there in regards to, end of life care and how that works and costs associated with that. So the goal of enhancing our health span should be the narrative of medicine as a whole, is to compress that disease window and grow into what Eric Topol calls our welterly, you know?
Hmm.
So I
Interesting.
think there's multiple different things. I like the biological 401k. I think, the harnessing a good vibrant microbiome is going to be critical. And you know what that looks like. How well is your bowel movements? Do you take a good shit a day? Like, when you go out and you start, deviating from your normal diet, your bowels change, right? And that's a reflection. I really think our fluids are a reflection of our health. If your urine is dark and cloudy and smelly and that's not good. That's kidney stress, right? It should be nice, clear, straw colored, right? With no cloud or cellular debris within it. And that reflects our specific gravity that ties into our ADH and vasopressin, that we were talking about beforehand. So there's multiple different kind of reflections with urine and fecal matter telling us a lot, right? And there's that whole Bristol stool chart, where that is used to gauge how healthy your bowel movements are. You don't need a chart to tell you, but the goal is to dial in, I think, all of these parameters for wellness.
Yeah. So, some of the negatives, I would agree with the things you said. Some of the negatives about, let's say, the epigenetic
Mhm.
tests, there's no, there's not a lot of ways that have been researched to actually reverse it or to slow it, right? There's limited research, I feel. I've seen some, but limited. What do you think about that?
So, I think there is that this is a new forefront, I think, of all sorts of stuff. I will make reference to the trim trial, that basically looked at, thymic involution and the regeneration of reversal of biological methylation, DNA methylation based epigenetic testing, and that grim age, right? Over a short course of time using metformin, DHEA, and a somatotropin, growth hormone, vitamin D, and I think one other agent. And they were looking at
So they
immunosenescence
use
as well.
DHEA,
Yeah,
but the thing
DHEA.
is, the problem with some of these things is they're not using one thing at a time. It's like, okay, let's do growth hormone and see what happens.
Well,
Let's do
this is
this
the
and see what
most
happens.
And I agree. This is the most notable trial, right, in regards to this biological age reversal, right, that's been published. And then there's been a handful of other trials that have kind of come out thereafter attempting to replicate this. The Dr. Kara Fitzgerald using more of a natural medicine approach with diet and lifestyle and, to move that signature. The Dr. Fahey study that I was referring to with the trim child that was published in Aging Cell in 2019 that basically observed an epigenetic age change of almost 1.5 years after, this intervention for a specific period of time, and also a kind of a rejuvenation in the
But you,
immunological age.
but you don't know which of the four things did it. That's the problem.
Yeah, no, and that's the thing, it's really gonna be hard to take into account these different confounding variables, right, with any study. And this could be argued that why my whole narrative is N of one medicine, because I don't think what's gonna move the needle for you is gonna move the needle for me exactly the same because our cytochrome P450s, our detoxification networks, are totally different. Our pharmacogenetics, and nutrigenetics is completely different, you versus me, based on our inheritance patterns, right? And the epigenetic signals. So I don't think, and you're absolutely right. What does a future look like? I make the argument that, medicine, we rely really heavily on these N values or patient participant studies that are in the thousands. The stronger the study, the more the people, the stronger the power.
Right.
But to me, the counter argument is we won't know what's really moving the needle, because the thing is, what if that person is on multiple different drugs? And we know that when there's a drug in the system for their blood pressure and their cholesterol, the secondary metabolites completely alter the terrain or the milieu of what's going on physiologically. So I think the future is going to be N of one medicine, where we're putting things into the context where we are the single subject variable in our own study, right? And the only way we could really understand what's going to move the needle for us is through, adapting some of these other kind of studies and seeing what they're doing, if there's a positive signature, and then applying it to us to see if it works. Because I could tell you now, some of the senolytic research that's on the horizon isn't too favorable in regards to its effect on biological age. Actually, I don't want to say too much, but there's a couple of studies that are going to be, published here soon. We're looking at these different senolytic agents, what we is being touted as, the next holy grail of aging science, is actually having very negative consequences on biological age. So
Well, I think that gets to another point, which is I think there's people using biological age. They're overemphasizing biological age. That right? They'll be like, "Oh, look
I
at my
agree.
regimen. Here's my biological age." You know what's probably more important than your biological age? Your blood pressure.
I would say
You
your
know,
blood pressure, your VO2 max, your
VO2 max,
endurance, you
exactly.
know?
Right?
Yeah,
Like your strength. How are they even figuring the biological age out? They're actually looking at these other metrics and they're saying, "Oh, somebody who's got more strength has a better biological age," whatever, right?
correct.
So they're using these external metrics, whereas like, oh, you could actually just use them directly. Like, what's your testosterone like? What's your blood pressure? What's your sperm count like? Who knows? You know what I'm saying? Like, you could use a whole bunch of different metrics. And for me, right, you could say I'm a longevity athlete. I'm interested in all of them, but how relevant is it to the regular person? Like, I don't know if I would recommend to people to get an epigenetic test unless you're like a longevity athlete and you're like, I don't care, I'm gonna, take 125 supplements a day, whatever, to get my biological age. But there's things like, let's say, that improve your biological age, let's say, right? Let's say growth hormone, right? Could be, we don't know. I don't know if they've done a study just on growth hormone. But what you see is like, okay, growth hormone is good for biological age. You know what? It's damaging for a whole bunch of other things. It actually causes you to age, right? Maybe you're stronger, and so that's kind of where biology is quite complex. Sometimes there's a trade-off, right? And so you see a senolytic, which is good in one way, and oh, wait a second, it actually increases your biological age. Oh, wait, so it's not good. And you kind of have all these confusing things that sometimes contradict each other. Maybe something that could decrease your VO2 max will also decrease your biological age. So what are you going to do? You're going to go after that, like, or your VO2 max. You want to go after the most impactful things. And I think the data I saw on the VO2 max, that's extremely impactful, right? Whereas
I
I don't I still I've read certain things on the biological age. I still don't know. I think it's useful, but is it how impactful? I don't think it's like the VO2 max. I don't think it's like blood pressure, right?
It's data. It's data. It's one
It's a
perspective
data
of
point.
data.
Yeah.
Yeah,
Exactly.
So I'm a data guy,
Too.
and I like to aggregate all this information into composite of kind of what our snapshot is of what I call our, kind of biological audit of the system, or a personal health inventory audit, so that we could have all these different metrics here to kind of work with, and the thing is, if about omics, you'll understand systems biology and network medicine. And the issue is with systems biology, and one of my, the researchers that I've looked up to the most in this field, two researchers, is Dr. Jeffrey Bland, the founder of the Institute for Functional Medicine, and Dr. Leroy Hood, the founder for the Institute for Systems Biology. And the thing is, when we really start putting things into the context of systems biology and network analysis, there are going to be things that are going to be going up and down and left and right and consuming and depleting and enhancing and growing. So the dynamic interactions for all of this is beyond our level of comprehension in our brains, I think. And this is where kind of machine learning, AI are going to have to pick up some of these different molecular signatures and signals to further elucidate the inner associations and connections on those levels. However, clinically, you're absolutely right. For me, I just opened up my second practice location right next to my jujitsu school. Right, I just came back from training jujitsu, and I'm surprised I don't have a black eye right now. I got banged pretty good, but I you know, I everything I do right now is to have fun with people like you, talk shop, health, wellness, right? I don't want to become your doctor where I'm micromanaging your blood pressure. I can, and we do. However, I want to become your health intelligence partner where I'm telling you, hey, I'm like your financial advisor for your biological aging process. And, for me personally, clinically, I just want to help my guys and my gals, that's why I am right next to my jujitsu school with this, and I'm getting all this fun equipment so we could just grow old together, choking each other for fun, you know?
Right. I guess my point is for people listening, like if you haven't done a test for your VO2 max, then don't think about biological age.
Or
If you
or
don't,
just do it all.
yeah,
The
or
biohackers
do,
that wanna do everything,
yeah.
get it.
No, no, I'm one of those people, and I plan on getting it. What I'm saying is, if you haven't done certain basic stuff, like gotten, people are giving me these functional, complex lab markers. I'm like, where's your basic lab test? Where's your CBC? Where's your CMP? What are you doing with all this nonsense? Like, This is like it's the margins, right? He's giving me his microbiome test. I'm like, where's your basic lab test? He's like, oh, I
Yeah.
haven't taken it. I'm
Yeah,
like, what are you
yeah.
doing here? So I think it's important. I like all the stuff you're doing. And I think when if you're getting a longevity athlete, you're like, look, somebody comes to you is like, I want the whole shebang, right? Do everything you can. Then I would agree. But if a lot of people, most people are like, they're pretty selective. They're not going to do everything, right? For cost purposes or whatever. And so I think if you're just a regular person, just my personal opinion, microbiome tests not worth it at this stage. At this stage,
Yeah.
right?
Well, it depends, microbiome, but stool analysis? Maybe.
Stool analysis, maybe if you have gut problems,
Correct,
right? So
correct.
then we're
Yeah.
talking about with a specific subgroup of people. But yeah, absolutely.
Well, and it's interesting because, like, for example, I'm actually giving a talk in Reno, Nevada with the Integrative Dermatology Group in October of this year on an integrative approach to, you know, digestive health. And I gave the same talk to the University of Maryland Grand Rounds. I gave the same talk to the Maryland Board of Nurse Practitioners. But essentially, what are you going to do with somebody that comes to you that's been seen by multiple providers, including a gastroenterologist, has been scoped up and down, left and right, and they basically come back and say, "Hey, take this PPI, proton pump inhibitor." What are you going to do with that? Right. But they still have gas, bloating, diarrhea, constipation, alternating bowel patterns, and so forth. You have to probe that a little bit further. And that's where I always say, hey, go speak to the GI doc first, get scoped up and down, let them rule out everything, put you on the PPI, and then we'll do a deeper dive. Because it could even be argued that food sensitivity testing has a level of bullshit, to it, in regards to its true clinical application. Now,
You're
I
saying the
do
IgG food sensitivity test.
so I think there's a difference between IgA, IgG, and IgG subtype 4 in regards to food sensitivity profiles. And each one's going to tell us a little bit of different immunotolerance versus sensitivity, right? So again, remember 70% of your immune system is in the gut associated lymphoid tissue. If you're eating the same stuff every day, a lot of that's probably tolerance, and then if there's, actual sensitivities growing to that same diet that you're consuming every day, that's a whole nother conversation. Right. And I do believe that giving your bowels a little bit of a break to kind of reduce that inflammatory burden and allow for your T cells to kind of, see that constant protein structure will have a benefit, but ultimately I do think that, your major insults, there's gonna
You
be
you think
dairy,
giving it
gluten.
a break is good?
Depends on the clinical situation, right? But if you have lactose intolerance or sensitivity, give it a break, right?
Right,
It's gonna
right.
inflame your bowel.
But
If
what
you
about,
got
something
gluten,
like, sensitivity to grains, lectins?
well no, you gotta keep in mind also that there's what's called a delayed hypersensitivity reaction, right? So these delayed hypersensitivity reactions could take upwards of 72 hours to clinically manifest that it's symptomatic presentation. So if you had something 3 days ago, it could be affecting you indirectly 3 days later, right?
Mhm.
In regards to anti-nutrients like lectins, what you just mentioned. So during undergrad, I did study with Dr. Peter Diadamo. I think he's freaking brilliant. He just won this year at the Integrative Health Symposium, his achievement award. Been studying his work, since, forever. Now, do I think the blood type diet is a holy grail? No, I don't. But I do think that from an
Oh, I
immunohematological
don't know
perspective,
about the blood type diet, yeah. I don't know.
so,
I wonder if that's there's legitimacy there, but yeah, that's a
well,
different question.
there's a study that came out of Toronto or Canada recently that tried to refute its efficacy and basically marginalize it. But if you were to read the study, the compliance rate was like less than 13% or something, crazy.
Mhm.
Again, how the hell this got published is just ridiculous. But again, I would view this strictly from the immunohematological perspective with lectins, meaning I choose in Latin binding to the cell surface glycoproteins that make up our blood type. And there's more than A, B, and O blood types that are there that are using, again, transplant medicine. So if you go for a transfusion, they're looking at Duffy, Kell, and all these other, Lewis A, Lewis B, all these different antigens within, our blood. And if you react to any, you're not going to get that blood, right, to be transfused.
Mhm.
But what was really interesting for me when I was working at MD Anderson, I'm sorry, yeah, MD Anderson Cancer Center in Orlando, Florida, was we had a differentiated A1, A2 phenotype for a transplant patient. So they reacted to a specific, kind of panel. And then again, to take it a step further, it's the same structure. It's the same glycoprotein, N-acetyl D-galactosamine or whatever it is, right? But there was a double bond somewhere in that structure. And that double bond had such a high affinity and avidity to this lectin from some bean, Doco, Loco, some crap, whatever it is to differentiate it, that it caused the red blood cells to agglutinate, right? So again, from a complement activation, so complement is, again, there's three different forms: the classical, alternative, and the mannose binding lectin pathways that influence complement activation, with the terminal kind of piece being the membrane attack complex, right? Which kind of ruffles up our immune system and causing all sorts of damage, so to speak, and activation of the immune system. We have the mannose binding lectin pathway. What do you think's going to happen when these lectins bind that are from our grains and from these different products to the cell surface glycoprotein, causing agglutination and complement activation? It's going to cause some stuff. You
Right.
know? And so again, do I think blood typing is a holy grail? No. Do I think it's a really cool collaborative filter to individualize medicine? Absolutely,
Interesting. Okay.
Um, yeah.
That's
So
interesting. I never had an opinion on whether I believed in it or not. I just kinda didn't know. So it's interesting to hear your opinion on that. So, yeah, I think going through some of the tests, I think, like, transcriptomics, I would also say is probably you're not gonna get enough bang for your buck for the regular person, right? Maybe a
for the regular
longevity.
person,
Yeah,
not so much.
right.
Not so much. For the
Longevity
chronically ill,
athlete, maybe, or you're saying not
maybe.
even. Yeah.
Maybe. So one of the things that mostly use it for is looking at a cluster of genes that influence mitochondrial function and nutrient signaling, right? Which are actually
Mhm,
very important hallmarks for aging. And oftentimes what I see is this molecular signature where your mitochondrial large and small subunits are turned down, your ribosomal large and subunits are turned down, your ATP synthase is turned down. And those are the people that are like, I'm tired. I'm always tired, right?
mhm,
And they have what's known as molecular hypometabolism on a mitochondrial level. And that's oftentimes associated with cell danger response. So if you're familiar with the concept of cell danger response, where your cells perceive danger and they respond by shifting the allocation of energy triage and triaging that energy, they're taking a very defensive cellular posture where they're not going to be at its highest vibrational operational frequency.
mhm,
They're taking that defensive posturing right now and turning down metabolism because of that perceived threat.
mm,
And that influences a lot of downstream kind of issues, your brain, mental health, fatigue, confusion, word recollection issues. And, you'll have decreased energy and endurance, cardiopulmonary endurance. I see a bunch of different patterns, with it, but it's interesting data again. But again, that's going to be heavily influenced based on your environment that you're in. And if you're shifting environments more frequently and shifting your diet, the signals might not always be there repeatably.
okay, but even then, you're saying this is for people who are chronically ill, and I mean, I'm not sure. So let's say you find that, okay, they have all this cell danger response pathway activated. It doesn't necessarily tell you what to do about it, number 1. And if you find that it's not active, I mean, how often do you find that it's active, let's say?
So again, I'm going to refer to the practice where I use that the most in the practice with my mentor, Dr. Andrew Heyman. And we see a lot of mold issues, a lot of chronic inflammatory response syndrome. And we will see various molecular signatures and patterns consistent with either mold, with MAP kinase signaling, and a couple of other
Yeah, but
um,
it's not specific
pathologies.
necessarily. It could be from VOCs or maybe
And then we also see endotoxemia, right, with toll-like
right.
receptor signaling. And we also
Also from other
see
toxins, could be from right?
mouth,
Right.
so forth. A good signature to point us in the potential direction of maybe needing further investigate, you know, because, or it could just be MCAS or mast cell activation issues. And we're seeing more of a signature of that that's kind of mediating the pathophenotype.
So somebody does those tests. My guess is the results are often not clear in terms of, or if it is clear, you could have guessed it without the test, right? Somebody's like has a bunch of symptoms. I got sick after living in this moldy house. You do the test. Oh, you got this transcriptomics, whatever. Well, you could have also just kind of looked at some of their history and maybe figure that out. Again, I'm
Yes
playing
and no.
devil's advocate here.
No,
So
yes and
feel
no.
free to disagree and tell me why I'm wrong.
No, I agree with a lot of everything you're saying, but clinically, one of the things that I do see is whether or not we have ongoing exposure, right? And if we have this ongoing exposure versus historical exposure, or
Mm.
the risk for cross contamination, we are seeing a molecular signature that would be consistent with this ongoing kind of environmental threat that's influencing our cellular physiology.
Okay,
And
fair enough. So if you're
one
seeing
of the things,
yeah, if you're seeing an
uh,
ongoing exposure, then you're gonna be like, "Okay, look, you didn't get out of that environment yet. You have to do a better
correct,
job there."
correct,
Okay, fair enough.
yeah. And one of the things that we are seeing actually, and I think this kind of more recent research and evidence that we've, looked at within Dr. Heyman's practice and has been published has to deal with looking at SIRS as a whole. What we're seeing is that actually 42% of individuals that are reacting to their environment are reacting to something called actinomycetes. Actinomycetes is a gram-positive filamentous anaerobic, facultative anaerobic bacteria that behaves like a mold. It's forms spores and
Mm.
is actually quite ubiquitous in our environment. You actually smell actino, you see mold. So the musty odors is due to
Ah,
actinomyces. And
interesting.
actually, there's even more emerging research and evidence that shows that individuals can be colonized with actinomycetes on their skin. right? Almost like how MRSA lives in our sinuses. If you've ever
Mhm.
worked in a hospital, lived in a hospital like most physicians and interns have historically, we're probably colonized with MRSA within our ears, in our nose, right? So it becomes a part of this resident microbiota and it actually produces a very toxic set of compounds, most notably mycolic acid, which punches holes into the cell membrane, causing it
Mhm.
to,
Mhm.
again, activate the cell danger response and additional threat. Now, what do you do? Right? There's a whole actinomycetes reduction protocol that has been kind of mapped out by some of these environmental health experts to further decolonize that. So, but otherwise, it would be how the hell are you going to know? There's no like skin test for it, right? Per se. There is actually there is a skin test, but there's an environmental test and things that kind of pick that up. But that's a whole nother world of microbiology that unless you're looking at the literature, going through the training, whatever, you're not going to pick that up. So again, needless to say, I just saved transcriptomics for the chronic complex illness, right? And in
And
my
it's not
longevity,
always necessarily, like, to see if they're
I don't
continuing. Yeah,
correct. I basically, that's a whole nother discussion. But in my private practice, I center around longevity athletes as yourself, other doctors that are, listening to other longevity experts in the space, whether it's David Sinclair or Peter Attia, and Huberman. Those are the bulk of the individuals that are finding me locally to kind of begin that kind of evaluation of wellness and longevity. And in my practice, I'm getting to the point now where I'm offering a very kind of exclusive high-end executive physical, where like I'm I've kind of spent my time, I've worked, the underserved populations and everything else. And, I'm now at this point where I'm just having fun with medicine and trying to kind of demonstrate how we could preserve our wellness and optimize our health through the lens of longevity based practices and principles. And this is why I like the data, and this is why I'm trying to make this more accessible and translatable because right now, outside of major academic institutions, it's really hard to find a provider to connect these molecular dots. Yeah.
absolutely. And what about, proteomics? Where is that? Like, that what would that include exactly? So, what kind of test would that include?
So you could do proteomics with these other kind of companies that are out there that are just going to give you a shotgun of thousands of different biomarkers, right? But the proteome, again, so the central dogma of biology is DNA into RNA, RNA into protein. We are already measuring all these different types of proteins within the blood. Homocysteine is a proteomic signature.
Right, okay.
Your lipid dynamics are proteomic signatures. So we're already looking at the proteome. And back to what I was saying, there's going to be four common clinical presentations: inflammation, oxidation, ischemia, and immune dysregulation that you would see proteomically speaking,
Mhm.
right? Now you could dial it into the granular stuff, but what are you going to do with that? The recipe for therapy is going to be the same:
Yeah,
movement, exercise, sleep, sunlight,
right.
hydration.
I think this gets into, I don't even know if I would do more detailed proteomics as a longevity athlete, but I think, like, I've spoken to enough people, and, like, almost every person I ask, I'm like, "Okay, have you uploaded your lab test in SelfDecode?" "Oh, I took a lab test 5 years ago." Right, like, they're not even taking regular lab tests, and I'm like, so I feel like a lot of this stuff is like, I would never even think about it. Is somebody taking, like, legit lab tests where they have so much thousands of published studies data on it, like homocysteine or whatever. Are you getting your homocysteine checked? Your your HbA1c? Are you getting your HSCRP? And not only getting it checked, I wanna see it, a lot of these checked every 6 months at least. Before you're doing that, forget about these, I mean, that's my philosophy, right? You're welcome to
And I
disagree.
agree. And I think what you're doing is trying to relate that to the primary care. And I think that's a very important bridge to gap. How do we have this narrative within primary care so that you could go to your PCP, primary care physician, and be like, hey, there's a few other additional biomarkers because you're absolutely right. Homocysteine, C reactive protein, hemoglobin A1C, LP little a, ApoB, right? These are all GGT, gamma glutamyl transfer. These are all
I
very
test these
important
all
surrogate
regularly.
markers.
Absolutely.
These are fundamental to me that I think should be kind of depends on how often you wanna be monitored, but it could be argued, it could be drawn quarterly or at least at baseline once a year, you know?
Yeah.
So it really depends on how obsessive you are with results and measurements.
My
But,
goal is once a month now.
that's hardcore. It's hardcore, you know? But, one of the things I love self-decode about is, again, one of the things I could share with you a couple of, clinical scenarios, but there was a patient that basically had a very strong family history of cerebrovascular accidents and injuries and dementia and a couple of other things. Normal lipid profile, right? LP little a was elevated, had the polygenic risk score from self-decode that was through the roof. LP little a north of 250 through the roof, right? And this is one of those things where it's like, what are we going to do about LP little a? You could have a completely normal lipid profile, but this separate, atherosclerotic risk factor that has been shown to hyperaccelerate vascular injury, aging, cardiovascular disease. What are you going to do? The best evidence we have is PCSK9 inhibitors like
Yeah.
Repatha, right? But additionally, the next best thing, there's a drug in phase 3 clinical trials called pelacarsen that's on
Is
the
that
horizon.
Novartis?
Yes, correct.
Okay. It's funny because they actually approached us. For our B2B service.
Yeah.
Yeah.
Yeah. I'm really excited for that drug to come through the pipeline. Some will say, niacin, high doses of niacin, but the tolerance level on that's very low. I actually embrace a flush. I love it. You know, it kind of comes and goes. I do think the slow release will have a little bit more dampened flushing effect, but the bulk of the studies, I know that all the lipidologists go to the AIM high trial. I don't know if you're familiar with the AIM
Yeah,
high
yeah, yeah,
trial.
yeah. Where it didn't show
That's
positive effect.
yeah, that study's bullshit. If you were to ask me, what other added benefit are you going to get when somebody is already,
On a
at goal
statin.
with their LDL, and on a statin? It doesn't make sense. That study is just, I think,
Well, I think there was a couple problems. So the way I see it is, number one is, first of all, there are side effects to a statin, right?
yep,
There could be some liver issues, especially when you're giving it at 3,000 milligrams. So I don't think 3,000 milligrams is actually a very good idea. I
of
think
which one? I'm sorry, a
niacin.
statin or
No, no, just
niacin?
niacin.
Correct.
Yeah.
Yeah, yeah, yeah. No, 3,000 is absurd.
Right, but that's
Yeah.
what this trial was like. That's what doctors give. They give around 3,000 milligrams, 2,500 to 3,000 milligrams. So I think that's too high, right?
Mhm.
The way I see it is 1,000 is probably a good amount, right? And you're
I
gonna.
agree.
The problem is the reason they don't give 1,000 because there's not enough of a clinical effect for LDL. Like, okay, you're gonna reduce your LDL by 10, 20 points, or let's say 10, 15 points, but is that gonna like? They want to see it go down, like 40, 50, whatever. So they're going to try to give the maximum dosage. But I think that's looking at it in a very limited way, right? So I see it as something that, all right, if it helps 10 points, I'm happy with it, right? And then because you also don't get the negative side effects at 3,000 milligrams, right? And the other thing
Mhm.
is you're, you, I take it with trimethylglycine because you're sucking out all the methyl groups with the niacin, and that could cause liver damage, and then you have other issues like insulin resistance, potentially some other issues as well. And so I think that, if you're already taking a statin, which I think the trial was looking at, right? They're already taking a
Correct.
statin. Your LDL is low enough that even if you bring it a little lower, you're not going to make a difference in the overall mortality, right?
Nope.
Like, at a
Correct.
certain point, the negatives of lowering LDL is not going to increase longevity. If you bring it to, 15, because LDL actually has some benefits in the body. And so
Cool.
all of these, like, I actually did a post on it with like 10 drugs and methods that reliably bring down LDL. The What you end up seeing is that they bring down cardiovascular disease for the most part, but not overall mortality, with the
Yeah.
exception of a statin, which actually has a bunch of other mechanisms of action. And so if you're already taking a statin and then you bring down LDL a bit more, you're just not going to see a difference in overall mortality, right? But yeah.
So that's It depends on who you speak to. The NLA, National Lipid Association, is, very gung ho about driving that LDL down to non-existent levels. However, one of the things that we need to keep in mind is that, cholesterol is a very important building block for hormones and neurotransmitters, right? So, yeah, and then so what's the innocent bystander, with driving down cholesterol so bad? And again, no mention or no talk of the other biomarkers that could be influencing the vasculopathic nature of what's going on. That could
Right.
be your TMO, like I said, ApoB, LP little a, your F2
Absolutely.
isoprostanes, your LPPLA2. So I think that's one of our greatest opportunities from even just a primary care longevity kind of standpoint is really dialing in the cardiometabolic dynamics in regards to saying, hey, let's work on that A1C
Do
and
you,
minimize that glycation process. The advanced glycated end products. Let's work on lipid dynamics. Let's fluff up those lipoproteins, niacin being a great source on that. Let's work on the phospholipid membrane bilayer, with rich sources of phosphatidylcholine, and a balance of omega-3 fatty acids. Now, I think a lot of people are overdoing omega-3s, which is shifting the membrane dynamics towards a very unsaturated, soft, easily lipid peroxidized status, but that's a whole
like,
nother conversation.
that's actually quite interesting. What do you think about taking like sunflower lecithin instead of phosphatidylcholine?
Yeah.
Phosphatyl.
Yeah, I don't think that's a good source. I think it is a source. The problem with lecithin, right, and depending on, genetics, your PEMT and a couple of other variables will influence how your body metabolizes choline. And choline, I'm sure you've seen, and you guys have articles on this, on how
Yeah.
choline actually it could be quite damaging, long term if accumulated in the system. So I think it really there's a couple of tests that I like to look at that break down, the phospholipid membrane bilayer. There's
Mhm,
one amazing test from Kennedy Krieger at Johns Hopkins
mhm.
that actually does a red blood cell breakdown of all these different kind of fatty acid and its byproducts. And then there's also like a
What is it called?
simple.
The test?
I get it through the company Body Bio.
Okay.
Yeah, you could order it through Body Bio, but you need to get it drawn and sent to Johns Hopkins at their Kennedy Krieger's Center, and it breaks down all the different phospholipids, the renegade fats, and all these different kind of ratios. But the goal of that is to look at it through the context and lens of balance, right? And I am a little bit more partial towards the work of Patricia Kane, with the PK protocol back in the day, and her lipid research institute that she had back in the day, and kind of Body Bio kind of picked up where her research left off, from my understanding. And so I think you don't want to go in there willy nilly and start overly aggressively supplementing and PUFAs, polyunsaturated fatty acids, such as fish oil, because it is highly reactive and then, susceptible to membrane lipid peroxidation. Keep
What
saying
would you
this,
say is the
membrane.
proper dosage?
I think test don't guess, right? I like to look at the omega-3 index and I like to dial it in around 6.4. There was a publication from the American Journal of
6.4 to
Clinical
1,
Nutrition.
so
No,
is
6.4 with the index.
what does that mean, though? Like,
So there is an index, and I think greater than 2.5 is considered normal, depending on which lab you go to. But there,
but what are they looking at? The ratio of omega-3 to omega-6?
no, just the overall omega-3 distribution. Yeah, there is a omega-3 to 6 ratios, and there are a bunch of other kind of markers there, as well as a whole. And the reason why I chose 6.4 is because there was a publication from the American Journal of Clinical Nutrition in July, I think, of 2021 that looked at the omega-3 index and associated it with longevity. So 6.4 or greater was kind of like where they like to see it,
Is that a
in that range.
percentage or
An actual index, yeah. So which one did you get done?
oh, okay, so I've got an omega-3 index, but
Mhm.
that is a percentage,
Okay, what is it? Yes. Yeah, that's a percentage. Okay.
and it's saying, like, above 8% is sufficient,
Hmm.
whereas below 8% is insufficient or deficient or insufficient. So mine
Yeah,
is 8.3.
beautiful.
Then it shows I have an omega-6 to omega-3 ratio of 3.3 to
Mhm.
1 and an AA to EPA ratio, arachidonic acid to EPA of 2.8 to 1, which it says is optimal.
Excellent.
So
Yeah,
that's
no,
kind of,
sounds
yeah, I
sounds
don't see
optimal.
the index here. But these
Yeah.
things also change pretty significantly. Like I actually upped my omega-3, didn't change my diet, and
Mhm.
I got a very different result, but that's mainly because I had a viral infection. So if you
And
have
you
any
gotta
kind
keep
of,
in mind,
yeah,
your body uses different fatty acids and iron, like ferritin, during these inflammatory insults or these infectious insults as a method to weaken the predator, right?
right.
So, you'll see these kind of what's called acute phase reactants that go into mobilization, right, when there's any kind of threat.
Yeah, absolutely. So actually, the thing that got most out of whack is the arachidonic acid TPA ratio. That went up
Mhm.
extremely, like pretty significantly, because I'm pretty sure that arachidonic acid helps fight against infections.
Well, it's signaling the inflammasome.
Right.
Yeah. So, yeah, there's a tie in there with like probably the NLRP3 inflammasome and how that's kind of primed by arachidonic acid.
Right. So
Linoleic acid is a really important marker. That linoleic to arachidonic is very important to look at, generally
mhm.
speaking. You want a well balanced linoleic level comparatively.
I want to get into a little bit of like what my framework is, really the self-decode framework, and then what you think about that. So the reason, I mean, again, you could say I'm a little biased, but the reason I really like self-decode is because you could learn so much information from one test, right? You see, nothing is in it of itself super definitive necessarily, right? But you're looking at a whole bunch of things that, 350, 400 predispositions that can then give you better ideas. You could look at, okay, what are the 25 to 50 risks here? And then you scroll through them, you can get a much better idea. And then on top of that, you could also get recommendations that take into account your genetics, your lab tests, and things, just goals that you are interested in, right?
Mhm.
And so the way I see like some of the basics of precision medicine, a lot of the things you're doing, I think, is part of precision medicine. But I think there's, like I said, there's some benefit, but there's a lot of, like, you really need a lot of expertise, and there's an expense. But the way I see is the basics of precision medicine is somebody has, you know a couple goals. Maybe it could be living longer, maybe it could be, they've got acne or gut problems or whatever, right? Everybody wants to improve something, brain function, energy. You look at what somebody wants to improve, and then you have a best fit model of clinical trials for to improve those things, of what recommendations will improve the most of those things, and maybe a person could rank order what's most important for them. Number 2 is you look at all the predispositions that are increasing risk for someone, and you see what is the best fit. You also rank them in terms of impact, but you see what is the best fit in terms of the recommendations, with clinical trials in terms of the recommendations. And then you could also do the same with labs, and then you could also look at specific genetic variants and kind of maybe increase the importance of certain recommendations. So those are the 4 methods by which I myself try to find things that work for me. And I guess I also do an additional thing that I wouldn't recommend for other people, which is I do megadosing experiments. But so that's kind of like my extra sauce. But the core approach that I have and Self Decode has is looking at all your genetic predispositions and then trying to give you a best fit based on that. So, in general, what do you think of the approach I just spoke about?
Well, Joe, you're a biohacker, when it comes down to it. I think, you're leveraging the best available information and evidence to help support, the informed decisions about, what intervention is going to be best for you. And I agree with everything you're doing. Maybe not the mega dosing component, depending on what it is, that could get you into trouble sometimes, you
No, that's
know.
why I don't
Um,
recommend it for other people. But yeah,
yeah, exactly. But as long as it's grass, generally regarded as a safe supplement, you
right.
should be fine. You might get some gastroenteritis or some GI upset from that. But otherwise, just embrace it. But for the most part, I definitely think that's exactly how I use self-decode. My practice is that I actually, connect the molecular dots because if, individuals are unable to move forward with all the advanced testing, I basically run self-decode with a robust, biomarker profile and to connect those dots. And basically, it's been incredibly informative, especially viewing it through the lens of polygenic risk scores. Again, if I have more of a chronic complex illness individual, I might be investigating other genetic companies. I try not to anchor onto one kind of platform, but I really, enjoy using self decode because of what you just said. You guys break down polygenic risk scores and hematopoiesis and red blood cell production and the predisposition towards elevated MCV and MCHC and leukopenia, leukocytosis or elevations in the white blood cell count, platelet activity. That's very important for me. You look at and you break it down into systems in regards to neurology, cardiovascular system, immune, metabolic, hematology, digestive and gut, all very important kind of clinical profiles. And then you have the biohacker profile, which is I really appreciate, where you go in there and take a deeper dive into some more of the nutritional associations and predispositions. And when you see that you have just like whatever it is, an increased propensity towards impaired detox or micronutrient deficiencies, you then go and quantify that with some additional level of testing so that you could begin supplementation. However, one of the things that I say is you never treat the gene. And I
Right.
can tell you there's a handful of individuals that have, let's say, a polygenic risk score or predisposition towards having elevated LP little a. And their LP little a is less than 75. So it's not always linear. They might be doing something already, whether it's the appropriate diet, lifestyle, and everything else, that's not going to allow for that gene to necessarily be expressed. So that's why, the genes will provide us with a roadmap and kind of a framework of your instruction manual of what we can look out for these genetic vulnerabilities and or weaknesses and or predispositions and work to augment that through, other forms of testing and interventions to kind of make it kind of formalized N of one curated wellness, so
Right.
that's
But there's a lot of things that I like I'm just to continue that a lot of people are not gonna test for. Like, most people, including myself, I haven't tested for telomere length. But guess what?
yeah.
This is genetic predisposition. It says I've got shorter telomere
Oh,
length,
no.
like a predisposition for it. So, that's interesting, right? I always found that I didn't do well with plastics. It says, well, I'm higher BPA sensitivity. It's not something that I'm going to figure out. Most people are just going to figure out. And so just random stuff like that, you could, get an interesting picture without doing a bunch of expensive tests. I mean, obviously, doing the test for everything would be better. But I mean, even if you do the test, it's still useful to know your genetic predisposition as well. Um,
Agree 110%. And
yeah.
that's how I begin the narrative with my patients is actually, looking at connecting the molecular dots as we go up the organizational transitions, into different structural components. But, starting off with your DNA blueprint to provide us with a roadmap of that instruction manual. And I agree. And that's what I really like is, another thing that I really appreciate about, self decode is that the polygenic risk scores are really important because I feel as though over the past couple of years, we kind of moved away from this concept of genetic determinism with just isolated SNP testing and looked at it in the broader context of epistatic relationships or gene-gene interactions to further map out this weighted kind of variable which is your polygenic risk score. So epistatics, as you know, is the gene-gene interaction, how the influence of one kind of gene influences the activity of another gene, and I think that's really important to take into consideration. And I also think that looking at things through that risk stratification tool with polygenics has tremendous benefit. But I still go back to it, and what I do with metabolic, with all of this right now with the self decode is map out some very specific genes that I do like to look at in the individual context to see how that influences, just personalized wellness. I go back to some of the more common ones that are used in functional medicine, Ben Lynch's, dirty genes and things of that nature to kind of map out and
So
tease out and parse out ahead of time.
yeah, I mean, when you get to these individual genes, So we do put a lot of these individual genes within relevant reports. And so you
Yep.
have, I'm sure you've seen that. One of the things that I think that we will be building, and I'm curious on your feedback of this, but it gets into the realm of hypothesis type stuff where, because if you have a study on some gene or SNP, like it really doesn't mean that much. And I feel like you really need a good observer. So what we're going to do is allow people to build whatever kind of reports they want. So, like, let's say you say, okay, I want to look at all these SNPs for this issue, whether it's mold or whatever it is. You'll be able to build your own report, and so you can put a client through it, and then just see all the variants that you are interested in, that you know about. Is that something that would interest you?
Absolutely.
Yeah. Okay. So,
Absolutely. Y Yeah, and there's, and the thing is, and also, there's so many different databases, especially with AI and machine learning, that are now mapping out, these different, based on GWAS study, genome-wide association studies, and pulling out these different signals that, and, again, correlation versus causation still needs to be worked out. But, these GWAS studies are definitely important at, I think, highlighting and uncovering some of these kind of, you know, new discoveries of how these genes are influencing things. But again, we use it as an additional tool, an additional clinical decision making tool that we could use to further help identify, understand, curate, customize, our protocols for our patients. For me at least clinically, there's not a lot of docs that are leveraging, genomics and in regular routine practice. But I think it's interesting. I was at University of Maryland. The medical students all got genotyped,
oh,
and they
they
got
did.
genotyped. Yeah, they got genotyped. And, these different centers of excellence, again, where they have these departments that are pushing this narrative of, pharmacogenomics, personalized medicine. This is the future. So, the upcoming generations of medical physicians that are, graduating from these more progressive programs are gaining insight and appreciation to this narrative moving forward.
Yeah, I think there's a big kind of gap in terms of you have this kind of medicine where things make sense, but they're not necessarily sanctioned by the FDA, right? It's like you have kind of all the tests that you're talking about are not sanctioned by the FDA. They're not saying like,
Well,
okay,
they're say I'm not too sure what you mean by sanctioned
sanctioned
by.
as in like
Yeah.
if that it makes sense to take this test for this disease usually, right? Like
Yeah, and that's a difference, I think, between
except the genetics
disease.
ones, like maybe some pharmacogenomics and certain
See, this is where
Mendelian
there's a
ones.
difference between, I think, disease and wellness,
Right.
right? And this is where biohacking might be in the middle. Right?
Well,
And there
that's exactly what I'm saying though, that the FDA is not sanctioning wellness, right? They're not
no,
sanctioning things that are gonna prevent disease. It's things that are either diagnostic or gonna treat a disease. That's what I'm trying to
correct,
say.
correct. Understandably so, right?
Right.
They're creating the standardization for diagnostics and disease treatment, right? So, but there's this whole gray area, preclinical, kind of pre-diagnosis, symptomatic presentation, pre everything that kind of presents itself earlier on. And this is where when you start working in the gray and you're realizing, hey, you're not a diabetic, but your A1C is at 5.7 and you're a pre-diabetic, and this is associated with all sorts of other downstream effects. What does that mean? Right?
Right.
There is a drug, the monoclonal drug based on the Canto study for like high sensitivity C-reactive protein, right? So oftentimes, so what do you do about, HSCRP that's elevated, like again, there is that Canto study that looked at this drug, but how much is that freaking drug? It's like
Right.
I think thousands of dollars. Or you could try to augment your, inflammatory signaling by looking at your diet, cutting out the bad fats, increasing the good fats, ruling out any sources of endotoxemia, dental foci, leaky gut, and so forth, and increase your anti-inflammatory regimen, right? Which is what we do on this side of the world of kind of health promotion. So it really, yeah, I hear what you're saying, and I definitely think that. It just depends on what you're looking at. There's a clear regulatory body, for some of these tests. There's a conventionally accepted regulatory body
Mm.
in regards to ICD-10 diagnostic code and how you diagnose, treat, and prescribe, this kind of manage this issue. But then again, there's a whole preclinical gray area, which is where the wellness world thrives.
Right. So I guess this is going to be the last part, and I want to go through some lab tests and kind of get your opinion on what do you think the optimal range should be, right? So something like ApoB, right? There's a lot of disagreement on what the optimal range should be, even within the non-mainstream world, you could say, right? There's the Peter Attia camp and maybe the other camps. But what do you think ApoB should be? What's the optimal range?
There's a couple of different ApoB profiles, So I did not hear what Peter Attia had to say, and I know that, the ranges could vary from lab to lab. I generally like to see ApoB lower than 100, generally speaking, and we know ApoB in the context of LP little a is a completely different story than LP little a alone. So I
Mhm.
like to put it in context with all your other different markers. I would like to see it ideally less than 80, but I'll take 100, you know?
ApoB, okay. 2 more that I got for you. Homocysteine, what do you like to see that at?
So that, if you were to speak to a lot of, the functional docs, they want to see it around 7, right? I'll take less than 10
You
as
take
a
less
as
than
a goal,
10. Okay.
So I think that could be argued, which way. And I know I'm sure you've seen and Self the Code speaks about, the optimal ranges for homocysteine and whether or not it still has clinical relevance in regards to its cardiovascular implications. There was a study that kind of came out that question that. I still think homocysteine is a great reflection of what's going on a level of methylation. I
Right.
also think you're going to have effects on alpha 2 platelet degranulation and hypercoagulability and other indirect cardiovascular stresses. So I again, I think the range for that one is 14 at LabCorp. I can't think of the units, but offhand right now, but so some will say
U-mol per
7.
micromoles per liter, I think. Yeah.
Yeah, yeah, that sounds right. But I'll take less than 10. I think really going in there and being aggressive with methylation, like if you're at 10, right? And you're like, "Oh my god, your homocysteine is greater than 7." And you go in there and hypermethylate, by giving these methyl donors, there is a potential for, you know, uh, negative
Going
outcomes,
overboard,
negative
yeah.
consequences with
Sure.
overmethylate, right? And then, even on a cancer level, I don't, there was a study that I remember a researcher from Dartmouth talking about, going in there with methylation, over methylating could increase your methylation of and silencing of your tumor suppressor activity, which isn't good.
Yeah, but you could also actually something that I actually found was even better than the methyl supplements was just NAC.
Yeah, yeah, I love N-acetylcysteine and glutathione, my goodness,
Yeah.
But again, this could be argued that you don't wanna go in there and overly reduce your terrain so that you're constantly reduced, right?
Right,
Because you need some
absolutely.
level of hormetic stress to induce some sort of resiliency. So I think it's a very, kind of you kinda retox to detox a little bit, and it's okay to have a little bit of fun and not, live in a bubble where if faced with adversity or stress on the system that you crash and burn, you know?
Okay,
Because I know people like that too.
last one, estradiol for men.
That's a great question. I would like to hear I generally depends on TRT versus no TRT. Some will say, 25 to 30, right? Some will say a
Okay,
little bit lower, some will say a little bit higher because estrogen is important for men, right? And then I would further want to break that down with some urinary metabolites to see the 2 to 4 hydroxyestrone estradiol ratios, right?
interesting.
To further map that out to understand if, because 4 hydroxyestrone, right, and estradiol are genotoxic. Those are very unfavorable. So again, and then I like to look at estrone as well. So E2 and
Mhm.
E1, within blood work. And I also like to look at the urinary metabolites. As you know, we can measure hormones in 3 different fluid compartments: blood, urine, and saliva. Each one tells us a different story. And to the audience that are, if they're still listening, yeah, at this point in time, there's a difference between total, free, bound, bioactive, and so forth. And I think understanding the full dynamics is really important because sex hormone binding globulin, or these different binding globulin proteins, are a real thing. Looking at your albumin and globulin proteins and the A to G ratio also is going to tell us a lot of what's going on. And then, is our estradiol coming from aromatization, because of these different other stressors. So when I see a higher GGT, uric acid, and ferritin with a higher estradiol level, not good, right? I think, you could think about aromatization in that kind of context.
Okay.
So it's putting
Interesting.
all the hormones together for, you asked for men, right?
Right, right, right,
So
right.
that was kind of my response here for men, generally speaking. I think back to, in regards to its associations with COMT, right? And how COMT influences estrogen
Mm,
metabolism, right? As a whole. But I also think about, the balance, the yin yang relationship, like with progesterone and alpha pregnenolone and its effect on,
mm,
GABA production and things of that nature. So, there's a lot of direct and indirect associations, but generally speaking, we oftentimes categorize estrogen as a female hormone, right?
mhm,
But I don't think it's gender specific, it's gender fluid, right?
right.
And we need healthy levels of estrogen within ourselves for balance as a whole. And it's going to have, multiple different impacts on different receptor sites and parts of the brain. For example, like testosterone for men, is going to help, really help enhance the locus coeruleus of our brain, and is going to give us our drive, desire, and our stupidity as well,
Right.
So, it has multiple different impacts,
Absolutely.
generally. Yeah.
All right, awesome. This was super insightful. I mean, there were other topics we could have talked about, but this is, we went over time, but super insightful. Yeah, appreciate it. You've been super insightful, and thanks for coming on.
Yeah, it's a pleasure.
And
And
where
we
could
we didn't
people
even talk.
find you? Yeah, sorry.
So I'm on social media, Dr. Anil Bajnath, doctor spelt out. I'm also with, my private practice with the Institute for Human Optimization. My website is ifho.org, and you could schedule a discovery call. And essentially, I'm licensed in almost every state in the country right now. So I have a pretty robust telemedicine practice. But again, I'm actually trying to have more like in-person contact. I really miss the human element of getting together with somebody and hanging out. And
Right.
I call it hanging out, having an appointment, right?
Right.
I do a lot of virtual, I do some, in person. And my goal is to, again, not be replace your primary care provider, but to become your health intelligence partner and connect the molecular dots so we could augment your aging trajectory. So
I like it. I might become
ifho.org.
one of your patients. I mean, I would like to. I don't really have any health problems right now, but I mean, just optimization. I think I'd be your worst nightmare as a patient. Like, okay, give me your supplements you're taking. Here you go.
Yeah, you already told me your laundry list, and I think, at a certain point in time, I think there's a point of diminishing returns, right?
Right.
And I
Absolutely.
also think, that, you're gonna have polynutraceuticals that are gonna be detrimental, right? So I love supplements. It's where I began my journey in this world with, integrative medicine. But I also am kind of minimalistic in the sense of, like, I think sometimes less is more. But
Right.
again, it depends on where you're at in life and what you're trying to do. I take, you don't want to look inside my refrigerator or my cupboard because I have, you know, a lot of supplements. I don't want to say a number, but it's north of 40, right?
Okay.
Do I take everything every day? No, I don't, right? I take holidays off of my supplements. I rotate them based on my stress of everything. Take different things based on different variables, so,
Mhm.
but my kind of blockbusters, is just going to be things around antioxidant protection, detox, neurotransmitters, brain health, cell membrane health, and things of that nature. So, generally speaking. But yeah, I'm always here. So if you need anything, just reach out. It's been a pleasure getting to meet you and speak to you. I really appreciate the work that you're doing and pushing this narrative of the quantified self and self understanding further. And I appreciate everything. Thank you.
67% of listeners aren't subscribed to the show, so please don't forget to show your support by hitting the subscribe button now. You'll not only be supporting the show, but also investing in yourself and your health journey, all while helping to keep us ad-free.